our pleasure to introduce Dr. Najwa. Dr. Najwa Al-Touil, Professor of Diagnostic Radiology, Faculty of Medicine, Hassan II University in Casablanca. Welcome in Egypt.
Thank you very much.
Thank you. مش كاينة هنا؟
هي فصلوا الشبكة هناك. هم قفلوا البتاع هناك. دي
هيشوفوا البرزنتيشن مش لازم يشوفوه.
بريزنتر شو صح؟
اوكي. لا اعمله. Good evening, everybody, and first of all, I would thank the organizing committee and especially Dr. Mohammed Fawzi and Dr. Mandouh Safa for inviting me in this amazing first international radiology conference. And my talk it's about small bowel obstruction, when to worry, and we have 50 minutes to talk about ischemia and CT findings ischemia, and we won't talk about diagnostic or specific causes. So, as you know, 50% of admission for acute abdominal pain is done by us, SBO, and the majority respond to conservative therapy, and that's very important because we know the role of imaging and CT in this affection. So mortality is high, between 2 and 8%, and 25% with ischemia and delayed surgery, and causes we have adhesion in 75%, and the others causes are shown in the slide. The danger in SBO is strangulation, and it's defined as an intestinal obstructive processes associated with intestinal ischemia, and it's a critical complication that increase morbidity and mortality associated with SBO. And early recognition of ischemia decreases morbidity and mortality from 25% to 2 or 3%. So it's very important to recognize earlier the signs of ischemia. And only patients who have strangulation should undergo surgery, and these operations should be performed as soon as possible to avoid transmural necrosis and perforation. So all radiologists know very well this paper. It talks about the diagnostic and when to worry in small bowel obstruction. And in this paper we find this we find this list with 11 items. As you see, there is any hierarchy for these signs, but we find bowel wall thickening, as Dr. Ayman Gaballa demonstrated, and mesenteric edema, fluid in mesentery and or peritoneal cavity, abnormal bowel wall enhancement, occlusion of mesenteric vessels, engorged mesenteric vein, Will-Sile, closed loop obstruction or valvulus, pneumatosis, mesenteric venous gas, and portal venous gas. So when we find some signs, we are proud and we put directly and automatically ischemia in the report. The problem is usually the surgeon, when he opens, he doesn't find any ischemia. So we are confused and we really need to determine which CT findings or combination of findings can help us to accurately identify strangulation and ischemia in SBO. So we do a retrospective observational single center study, and we select only patients with adhesive SBO because it's the most frequent, and these patients were examined by using contrast enhanced CT. Among 268 SBO, we include 110 patients who underwent surgical procedure within 24 hours of CT. So when we have more than 24 hours of CT, the patients were excluded. And we find only 64 patients of whom were found to have strangulation. So only 59% who has a really strangulation. So we decide to study the frequency of each CT findings compared between two groups, one with strangulation and one without strangulation. And we do a univariate analysis in the first time. And the second time we do a multivariate analysis. So we by using Pearson or Fisher exact tests as appropriate, and continuous variables were compared between the two groups by using Wilcoxon rank sum tests, sensitivity, specificity, positive and negative predictive values, and their exact binomial 95% confidence interval and Youden index were calculated for each CT findings. So we have this result. So we see here the results of univariate diagnostic analysis. So all evaluated CT findings were significantly associated with strangulation, except feces sign, who has a locator value, and free peritoneal gas and pneumatosis or venous gas. So it's really bad for us, because when we find the peritoneal gas or pneumatosis or venous gas, we see easily that it's strangulation, but it's not finally. Pneumatosis, mesenteric venous gas, and portal venous gas, it's very rarely to see this sign in SBO. It's not specific for ischemia, and we think that the gas is generated for mechanical elevation pressure, a kind of barotraumatism, and not really a problem of vessels or congestion. And so in the univariate analysis, the most sensitive sign is closed loop mechanism, and the most specific one is a decreased bowel wall enhancement with a high specificity. So what about other signs? The Wirral sign isn't sensitive and isn't specific, because we find it usually in many cases even without obstruction sometimes. It's a sign of a mechanism, of a volvulus mechanism, but not ischemia. ascites and thickening wall is a sensitive sign, but really definitely not specific as Dr. Gaballa demonstrates in his slide. We assess a careful analysis of mesenteric changes, focal versus diffuse mesenteric haziness versus mesenteric fluid. The important for us is the diffuse mesenteric haziness and edema. So in the second time, we do a multivariate analysis. So 3 CT findings were significantly predictive of strangulation. Similarly to sensitivity analyze and are reduced bowel wall enhancement, diffuse mesenteric haziness, and closed lobe mechanism. So this combination of 3 CT findings is accurate for identification of strangulation with excellent diagnostic performance with an area under the curve 0.91 and 95% confidence interval between 0.86 and 0.96. Of interest, the pathophysiologic process in bowel obstruction, indeed one sign relates to bowel wall perfusion is reduced bowel enhancement, and one to mesenteric congestion is diffuse mesenteric haziness, and one to a mechanism of strangulation is the closed lobe. So what is the implication for a patient care? So by combining 2 or 3 2 or all 3 CT findings, the need for surgery in adhesive SBO should be suggested. Whereas the absence of these 3 CT findings should, because of the high negative predictive value, suggest the need for medical management. And the presence of only one of these 3 CT findings is not sufficient to opt for surgical care, except when we have a DBO or DMH. We must absolutely check the mechanism because this sign never come alone. So sure, our study had limitation. First, it's a retrospective single center design, and the small number of patients with strangulation, you have a chance in Egypt to have a big population, so we invited you to do a study very stronger statistically. Second, we select only adhesive SBO because it's the most cause frequently. Third, we didn't investigate mesenteric vascular engorgements or congestion because it's weak reproducibility between readers. So I conclude with this. I propose you to replace this old list by this one. 3 independent predictors of ischemia, decreased bowel enhancement, diffuse mesenteric haziness, and closed loop mechanism. And the implication of patient is here. If 2 or 3 surgery, if no one medical, if one sign, it's a closed mechanism medical treatment. And when we have DBO or DMH, we must absolutely check the mechanism another time. Surely the closed loop is here, but we misinterpreted him. So thank you very much, and I would share with you this photo, this picture of the second the King Hassan II Mosque in Casablanca. Casablanca is the biggest city in Morocco, but it's not as bigger than Cairo. I'm very happy to invite you in our Congress in May 19 و 20 و 21 مايو إن شاء الله. It's a French speaking, but we can program English session علشان عيونكم. Voilà, merci beaucoup.
Thank you. Thank you very much, Doctor, for an excellent lecture.
Thank you.
And